So in this session, we're going to be talking about ensuring that research findings are taken up into policy and practice. And, you know, just speaking personally, I found two things really important in this aspect. The first seems very basic, but is really important. If you want somebody to listen to your answer, then answer their question, not your question. Make sure you're answering the question asked by the implementers, not the question that is of most interest to you as an investigator and a researcher. And this takes it to the next stage, because those best placed to ask those questions are the people who are implementers within the health systems. And we'll go one stage further than that and say that often the best people to research those questions are those very people who are asking them in this way. I think we really need to realize that research is a spectrum, and it's great. And some of us have got a background in academic research and we go for that, but it also needs to be a tool in the hand of implementers. We need to democratize the research. We need to make sure it's available and usable for everybody. The second really important thing is a really simple phrase, is that what is important is not what you are saying as a researcher, but what the policymaker is hearing from you. And so communication is the second key to this. So making sure that we're able to communicate what we are doing really clearly. And I hope some of you came to the AMR symposium yesterday, where we were showcasing TDR's structured operational research training. And as part of that, we now train people not just to do the research, but actually to develop policy pitches, all the way from meeting a minister in an elevator to bumping into somebody at a conference. And I've got some breaking news right now. Just an hour ago on my phone, for the first time ever, we've got a journal, and this was the MDPI journals that publish tropical medicine and infectious disease. Underneath the abstract are going to publish a flash presentation by the investigator explaining the policy relevance of their research. So the story can be taken across. And literally, I haven't got this, but Ronnie Zachariah, Ronnie, do you want to just give a wave there? Is the lead on sort it for TDR. So if you're interested in following up on that, please catch Ronnie a little bit later, but really exciting news and really important. So answer the right question, make sure you're framing that answer in a way that can be taken up. And let's hope we're going to see some of these examples as we work through our panel today, some fascinating talks to be discussed. So I'll move very quickly and introduce the plenary speaker. And the plenary is Dr. Aliya Naheed. Aliya is a health systems specialist at icddr, and also she is the lead for the Global Health Network and the Asia Regional Coordination Center. So thanks, Aliya. I'm looking forward to hearing what you've got to say.
Thank you, John. That was a kind introduction. And what a pleasant morning and excellent opportunity to speak in a plenary of the first The Global Health Network conference. Congratulations. So I'll try to give a experience that we walked through in Bangladesh and also with other countries in building research into health systems. I'm not going to present in research, but I'll try to give some essence what we learned from it. At a glance, Bangladesh, probably most of you know where it is. It is a small country neighbored by India, Myanmar, Nepal. And it is a small country, but more than 165 million people live here. And density is pretty high, and 1/3 people live in urban areas. But the health expenditure for people is so low, as low as 2.48 GDP per capita, and it is only $46. More than 73% of health expenditure is borne out of pocket. This is quite substantial. But there's some good news. Bangladesh has achieved Millennium Development Goal ahead of time by reducing the child mortality and maternal mortality. More good news continues. It has excellent economic transition, and the per capita GDP is now more than 1,500. That surpasses many other neighboring countries. In the past 16 years, life expectancy has substantially increased for both male and female. And as of 2020, life expectancy is 73 years. Quite impressive. But there are backsides. Along with this economic and other transitions, the country has tremendous epidemiologic transition of diseases. If you look at this bar, the blue bar represents infectious diseases deaths in MATLAB Health and Demographic Surveillance located in Bangladesh, which is the longest health and demographic surveillance in a lower developing country. And the red bar shows the margins of non-communicable disease deaths in the population. So the blue bar is narrowing over time and the red bar is emerging and it is expanding further. Indeed, non-communicable disease is attributing to 71% total deaths in Bangladesh. And the sad news is 46% of these deaths occur in younger people, 30 to 70 years of age, which is we mark as premature deaths. The trend that is projected for Bangladesh is probably not going to meet the goal of reducing premature deaths of 25% by 2025. This is concerning. And more concerning that stroke and ischemic heart disease, those are the two top killers that constitute cardiovascular diseases. That is 1/3 portion of the NCD deaths. But the good news is, it is hypertension or raised blood pressure that actually attributes to cardiovascular disease risk factors. And evidence suggests very strongly that just 2 millimeters of mercury reduction of the systolic blood pressure can reduce 7 to 10% of risk of heart disease, stroke, and other related deaths. How amazing. And the hypertension burden is emerging. Every 1 out of 4 adults have hypertension. 60% of them do not have their pressure under control. And 1 out of 3 individuals more than 40 years have chronic kidney disease developed, most of them accompanied by heart and stroke episodes. And these estimates are higher than other countries in South Asia. The problem is, this is a health systems approach and we need health workforce to provide services to huge community, but there's a scarcity of healthcare resources. We have more doctors than nurses and paramedics, and we have more private hospitals than the government hospitals. And they're mushrooming of private hospitals, although they're expensive, people go there because of their convenience. So the situation doesn't look good for hypertension control at the moment. But what we did, we came up with a multi-component strategy for hypertension control in South Asia, and 3 countries implemented a strategy called COBRA PPS. COBRA is not a snake. It is control of blood pressure and risk attenuation in 3 countries. The multi-component actually was driven by grassroots level health workers who were trained how to measure blood pressure and how to educate population with hypertension and their families to reduce the risk of NCD, such as promoting healthy diet, increasing physical activity, reducing smoking and salt intake, and reducing stress and alcohol intake. These health workers, when they measure blood pressure, if somebody had problems, they referred to a nearby facility, which was a part of the intervention, and they documented it. And in the facilities, there were doctors who were trained how to treat hypertension following an algorithm-based case management guideline that did not exist in the country at that time, and also treat associated comorbidities. And there was a triage coordinator who is the chief of that facility, who actually coordinated, monitored, and supervised the doctor's work and the health workers' work in the community. Only problem was that there are many poor patients and some facilities were farther from the community. So for the poor patients, the component of financial compensation is included. But challenge remains because drugs were not abundant, and traditionally only 3 to 7 days drug supplies were offered. But for a hypertension patient, they need months of supplies. How can they come every 7 days to pick up drugs? So we coordinated, negotiated, mobilized the government to supply drugs in the centers so the patient can have at least 1 month drug supplies and reduce out-of-pocket cost. So after the 2 years of research and trial, we saw fantastic finding. Both the systolic and diastolic blood pressure at the community level substantially reduced. And this is a significant achievement in all 3 countries. And this study was published in high impact journals, and the analysis of economies also suggested that a country like Bangladesh, we need only $10 to scale up this program across the country in 2 years, and it is such a cost-effective program. But it was not scaled up. But at the local level, there are a lot of impact. Doctors continued their treatment practices. Community health workers continued their screening blood pressure and educating their neighbors. And the government actually adopted the treatment protocol to have a national treatment guideline and develop national guidelines for lifestyle modification. So lots of the good things happened. One of them was, this is for the first time, NCD drugs were available in all health facilities in the country that is run by a government, what is not thinkable before. But COVID came in 2020, and all these efforts were stopped. And we realized that we, the parachute scientists, come from an organization, land in a country, land in a community. We do the research and go away. Where is the benefit stays? And we realized that it is a complex, health system is a complex, but we need to integrate some element to make it a holistic care ecosystems. While we're treating patients, at the same time, we need to identify people at risk who should be given preventive care so that they don't develop the risk and they don't develop the diseases. Because once the disease is there, it cannot be cured. You have to carry it for lifelong. And we were really looking forward for a auxiliary task force. What can that be? And we found digital health solution. And we realized that maybe digital health can help us augmenting these processes and help us scale up. And what we did, we transformed the entire manual model into a digital model so that every health worker at the community, at the facilities, they can have an apps that they can use for screening, referral, treatment, and monitoring the patient for lifetime. That was an excellent work. But where is funding? So what we did, we looked for different organizations and got very little funding. But we realized that just having a rural solution will not be enough for the country. So we developed an urban solution, which is catered by the health service, catered by another ministry, not by the health ministry. And of the most vulnerable population in the coastal areas, 33 million people where there is no health systems. So how we can make it a comprehensive model for all these communities so everybody benefits from it. But the thing was, this is again, we go down to the community, do a research and come back. But we need to make an infrastructure and setting and capacity so that data and services are offered on an everyday basis, not by the researchers, but by those people who provide the services to patients on an everyday basis, be it in a community clinic, be in a hospital setting, or in the community programs. We need to develop build infrastructure and develop capable team to collect data, analyze data, and give it to the managers so that they can actually make decision for improving their care and give benefit to the community. So we came up with research capacity building for the vision of building a lasting, capable leadership team. Okay, so I think I just go for there. But we realized that doctors need to be trained how to do research. And we have a platform of clinical research, Bangladesh. And the goal was to teach the doctors how to do research and encourage them to share the research findings. For 18 months, it went well, but when the funding dried, everything stopped because doctors don't have time. They only have incentive for seeing patient. No incentives are given for publishing research. So we realized that we need to revitalize the entire program, not focusing on doctors, but also focusing on other health cadres. And it has to be a system that allows the healthcare provider as identify their own problem and develop some research question, collect data, synthesize data, and collaboratively analyze data and generate evidence for solution, local level solution. So make small change for strengthening their health system so that they can translate those benefits into their everyday routine and improve quality of care. Then we developed a new ecosystem for health research and data science, not in isolation, because we realized that solutions in one country is not adequate. We need to learn from other countries. And countries in Asia, they share common culture, common practices. So we need to have a regional network. So we developed the Global Health Network Asia in collaboration with our partners in the Global Health Network in the UK, in Oxford University. But we did not stop there. We also reached out to the Latin American programs, our colleagues there, and also African colleagues there. And we really look forward to 5 years program for learning research capacity and how to train the health service providers and create a data resource, make reusable data, and strengthen research and data science environment to have a federated global strategic partnership for better benefit. And of course, it is data ultimately that matters. And we created a global health data science. And the mission is to create a champion in each and every country who becomes a member of the network, who will give a drive to look for existing data that is sitting there and try to reuse it to identify evidence, rather reinventing another wheel, and create a collaborative platform and common data repository and build skill to analyze them to have local evidence and again, getting local solution for identifying common problem, common solutions, and identify a path to scale for best practices. And the vision is to get all trained team, empowered community, research governance, and ultimately reduce the NCD multimorbidity through service policy strengthening and for better health. And that is the only way we can reduce morbidity and mortality, and research will be a core activity for that. But just to keep in mind, we just can't be focusing on one population. We have to think through life cycle, and we have to think about all those risk factors that can amalgamate to have NCD diseases in adult age. So this could be a life cycle approach, not only in the human life, but also research ecosystem. So each and every health service facility should be brought into the program. So let me show you this picture on the left-hand side. This is the train. Can you see the train? People going home, and this is a common picture. You can't see the train. So this shows how crowded a country can be. And in a crowding like this, after pandemic of COVID, you should be worried, right? People are not wearing masks. They will die if the COVID is there. So you can imagine, pathogen doesn't static. Pathogen doesn't have boundary. Pathogen evolve. We are not as smart as the pathogen to beat them, or the conditions in the body to beat them. So we have to unite. And the right-hand side shows the Global Health Network Asia, where we have partners from India, Pakistan, Nepal, Sri Lanka, and Bangladesh. And we are going to look forward to creating leaders who will create the Global Health Network country-level programs and improve capacity of research for improving health service delivery in those countries. With those few words, I just want to remind you that when we talk about One Health, we probably forget about diseases beyond infectious disease. We probably forget about conditions beyond pathogen. There are environmental factors. There are other diseases. So let us unite and think of a new definition for One Health today. Thank you.
So let's move on to the panel, and we have a really exciting range of different activities here. And our first speaker is Vivek Dsouza. Vivek is from the Institute of Public Health in Bengaluru, India, and he's going to tell us about implementation of tobacco control policies in India. Please, Vivek.
Good morning, everyone. At the outset, I'd like to thank the Global Health Network Conference, the conference organizers, and the University of Cape Town for giving me this opportunity to present some of the research findings of the work we're doing in India. So the topic of my presentation is the lessons learned from 2 regional consultations on strengthening the implementation of tobacco control policies in India. Tobacco is a global issue having far-reaching local consequences. Tobacco kills around 8 million people globally, and India shares a large burden of tobacco where tobacco kills around 1.3 million Indians each year. Tobacco use prevalence in India is pretty varied and diverse. As you can see in the map, we have almost 267 million users, current tobacco users in India today, out of which 10.7% roughly smoke cigarettes. A majority of the adults in India smoke BD tobacco, which is a local variant of the tobacco in India. 38.7% of adults are exposed to secondhand smoke at home. And the prevalence of smokeless tobacco use is almost double compared to smoking cigarettes, with 21.4%. So what has India done? India has been a front runner in the enactment of comprehensive tobacco control legislations. It ratified the Framework Convention on Tobacco Control in 2004. But even before that, a year earlier, we had the Cigarettes and Other Tobacco Products Act, or COTPA, in 2003. Starting 2007, the government of India enacted the National Tobacco Control Program, or the NTCP, which is a governing body that oversees the implementation of the tobacco control laws in the country. And we also have Food Safety and Standards Regulation Act of 2011 that regulates and prohibits smokeless tobacco use. But despite having these laws, India faces a lot of challenges in implementation. However, what is important to note is that this is not unique to India or to tobacco control. Many countries in the LMICs also face similar, if not same, challenges in several health programs and policies. In India in particular, and in the context of tobacco, there are different and varied forms of tobacco products available. Exposure to tobacco also influences and is determined by your age, your social location, low education and income status, and urban and regional variations. We also have the problem of tobacco industry interference. But more so, implementation of tobacco control policies is hindered by several organizational and health systems challenges. We have fragmented government structures, competing interests in terms of tobacco, where certain ministries or departments are against tobacco due to health reasons, but certain ministries and departments favor tobacco because tobacco is also grown and produced and manufactured in the country, and there is a lot of revenue generation and taxes due to it. There's lack of resources, poor coordination and enforcement, and very little data to review and monitor these policies, and illicit trade. So what did we do? How do we then understand the implementation of the tobacco control laws, and how do we strengthen these? More so, how do we create an enabling environment where both researchers, policymakers, and practitioners come together to discuss and debate how best to strengthen these policies? So we organized 2 regional consultations, and we use this as a method amongst several methods in our 5-year mixed method study. We developed and implemented regional consultations under the theoretical framework of realist evaluation, which is a principle that's based on the understanding that there are several contextual factors when a program or policy or an intervention is implemented, and these contextual factors interact to create several outcomes. So our objective of organizing these consultations was to understand, in Indian contexts, what kind of mechanisms did or did not work, which resulted in different tobacco control outcomes. So we started with a stakeholder engagement process where we identified several stakeholders who are directly as well as indirectly responsible for implementing the law. We used our existing networks and leveraged these networks because the organization used to also previously work on tobacco control advocacy. So we use these networks to identify certain stakeholders and include them in these consultations. At the same time, we had also collaborated with the Southeast Asia regional head of an international organization, which is based in New Delhi. And we started first by sending them emails and then also calling them. For the stakeholders that didn't respond to those emails, we called them again, and then we did a follow-up. We met each of the stakeholders in their states, and then we organized the 2 regional consultations, one online and one in the Indian state of Chhattisgarh. And within each regional consultation, we conducted 4 focus group discussions based on the 4 strategies that are prioritized by tobacco control. One is the awareness, enforcement, intersectoral coordination, and on tobacco industry interference. So these were some of the results. Around 19 states in total in India participated in the regional consultation, both online and offline. The regional consultations were a platform or a space for state-level implementers, tobacco control specialists, practitioners, and people from health, research, and other allied sectors to present their work and to talk about the barriers and challenges that they face. So some of the concrete action plans that were that came out of this deliberative process was that there needs to be a comprehensive manual that outlines the implementation. This manual needs to have ministry-wise or department-wise guidance, and this guidance can help in organizing such meetings, issuing letters from higher authorities, reporting progress to the state-level authorities. Considering that tobacco use is a risk factor for many NCDs, and people who live with HIV, TB, and other non-communicable diseases are also they are faced with the issue of tobacco, there was a realization that there needs to be advocacy across health programs in order to improve and prioritize on tobacco control. States and districts need to be empowered and act beyond the existing laws. There was a challenge in communicating what is tobacco industry interference and why is it a problem. So the underlying recognition was that there needs to be a common language in identifying industry interference and why that is problematic. And the fact that government, CSO, academia partnerships need to be formalized. So these were some of the lessons learned and challenges. Initially, the stakeholders were reluctant to participate because they were unaware of how their participation will help in improving the implementation of the law. Stakeholder engagement requires time and money. And we realized during the process that we need buy-in from senior level bureaucrats before approaching the juniors who are implementing the law. These are some of the lessons learned. Thank you.
Thanks very much, Vivek, and perfect timing. I saw you finish just as the sign went up. So I have to admit, I've been a little careless of chair because I seem to have lost the next speaker on your program. But don't worry, we can move on past that, and we have a great talk coming up from Kutha Banda. And Kutha is with the Clinton Health Access Initiative in Zambia, and she's going to tell us a bit about the implementation of data to policy training. Thanks, Kutha.
Thank you. Good morning, everyone. My name is Kutha Banda, and I work with Clinton Health Access Initiative in Zambia. So the delegation book indicates that I'm from Malawi, but I'm sure my ancestors are from there. So I'm here to just share a few lessons from implementation of the Data to Policy program that we have running in Zambia. So we do know that knowledge translation is really this gap between the know-do gap. We know that in most cases, researchers are going to use quite complex language to communicate their results. And in some cases, we find that decision makers may not be technocrats to be able to understand the odds ratios, the relative risks, and so on. So we really want to bridge this gap to ensure that the knowledge that is being presented is easy to uptake. And in Zambia, the National Health Research Authority has been implementing this program called Data to Policy. We call it D2P in short. And it's a capacity building program that facilitates knowledge translation. And we've seen that at national level, it has informed decisions that have been made. Now, we did realize that at sub-national levels, there's very low utilization of knowledge to make decisions. And so last year, with support from Sweden, we were able to, adapt this national program to have a sub-national data to policy program, just to adapt it to ensure that we're taking into account the decision-making levels and authorities that exist at the sub-national levels. So how did we do this? This process started with having this agreement with the National Health Research Authority. And like I said, we're able to adapt the curriculum that was existing and develop a curriculum that had about 16 modules. I won't go through all of them, but I'm happy to have that discussion as we continue engaging. And so after we developed these modules, we then started implementing with the first unit that involved modules that talked about problem identification, using different tools, doing root cause analysis. And I'm happy that this morning there was a discussion about utilizing routine data, because this program actually encourages identifying the problem from the routine data that we have, and then also conducting policy analysis. And thereafter, it's a mentorship program for 6 months. We then had weekly online check-ins. We had mentors and mentees. And then we also had initial stakeholder engagement. We had to ensure that there's buy-in from the stakeholders from the beginning. They are part of the process of identifying the problem. And I'm happy to report that we had the sub-national officers, the frontline officers being part of this cohort. And so they are able to identify the local problems that they have, and also to identify the interventions that they think should be made policies to address their problems. After this, we had a second unit. This involved economic evaluation. So we did realize that decision makers, this is quite an important aspect, because they want to know whatever you're proposing, what is the impact, what is the effectiveness, how much money do they need to put into it, and so on. And after this, we continued the virtual sessions and then moved to the more practical aspect of conducting the economic evaluations. And then we had the last session that focused on policy advocacy and communication. And following which, we continued stakeholder engagements, and we had a policy forum at the end where policy briefs were developed. And we're happy to also report that we had parliamentarians part of this. And so it was a very acceptable process, and the recommendations were quite acceptable. What were the results? So we had 6 policy briefs developed from this process. One that was looking at measles vaccination, how to improve that. Another one focused on how to improve antenatal attendance in the first trimester. Another one looking at, iron deficiency and anemia in children. And one that focused on teenage pregnancies. Another one looking at addressing stillbirths, preventable stillbirth. And then we had a last one that looked at intimate partner violence. What are the strategies? What is it that we can implement to reduce this? Some of the challenges, I've just highlighted a few high-level challenges, which is the time commitments that the participants need. So this curriculum was meant to be delivered in 4 months, but we're able to be flexible and run it within 6 months to take into account the fact that these are frontline officers. So they have their day-to-day jobs, and it's quite an intensive course. And then we also looked at commitment of the mentors, particularly the health economists. You would know that most of the participants were coming from the health background. So epidemiology and things like that were a bit easier for them to follow. But when it comes to doing economic evaluation, it requires a certain level of skill. And so some of the mentors were also a little busy because there's a few mentors in that area. So we tried to have a lot of in-person meetings, bring people together. And of course, that had a little bit of an implication on costs. Yeah, but that was able to get us to the end of the evaluations. And also another aspect was lack of access to certain articles, especially those that looked at effectiveness of different interventions. So there were some articles that required, of course, you to pay to access them, but the team that we had are from a public institution. And so being able to pay for access to those articles was a challenge. So we're able to use the articles that we could find. And in some cases, when building our models, we're able to note that these could be the limitations if it's not very close to the context, to our local context. So our next steps from this program is, now that we've developed these policy briefs, we've presented them to the decision makers. The decision makers are happy and they would like to see these interventions done, but we now need to look for resources to be able to actually implement them in our settings and see how effective they'll be. And also would like to roll this program out to, more frontline officers, would like to have more nurses, clinicians from the health facilities, because then they get to appreciate the importance of the data that they are collecting, the routine data that they are collecting, and they feel like they are part of the solutions, because them being on the ground, they do know some of the interventions that would work. So we want to roll it out to those frontline officers. And would also just recommend some level of access to, a lot of journals, especially for those in the public sectors, because we do know that funding in the public sectors is quite a challenge. So asking me to pay $300, $400, it's not something I can easily do here. And then also, if anyone would like to implement this program, it's quite a good program, especially if you are bringing in the frontline officers themselves to develop their own policy briefs, walk through the process to develop the interventions that they would want. So it's just important to set expectations of the time that is required. It is an intensive course, but it is quite acceptable, and setting those expectations from the beginning for the mentors and mentees is important. I would like to acknowledge the National Health Research Authority, Sweden, Ministry of Health, the CDC Foundation that worked with the original curriculum, Vital Strategies, and the Bloomberg Data for Health initiative. Thank you.
Thanks very much, Kutha. So our next speaker will be Elodie Chevallier. And Elodie is from the Institut Pasteur in Madagascar. And she's going to be talking us through the really interesting challenges of improving prison health in Madagascar. Thanks, Elodie.
So, hi, everybody. I will present you today the process that we made to help improving prison health in Madagascar through knowledge translation and what innovative and challenging it was. So first, let me introduce you prisons in Madagascar. The overcrowding by more than 400% of the capacity. There is also a problem of limited access to water with poor sanitation infrastructure, water cuts, and all of this increase the risk of communicable disease. There is also a big problem of food access. The penitentiary administration provides only 300 grams of manioc per person per day. So this has led to 30% of chronic malnutrition and all the related disease as tuberculosis. There is also a limited health access. There is no doctor in the prisons, only nurses, and a very low ratio of caregivers to inmate. Actually, there is more than 30,000 prisoners in the country and only 60 caregivers in prison. So it's in this the MIAN project takes place in this context with the aim of contributing to the improvement of the overall care of tuberculosis and HIV infection in prison through 3 components, including investigation. So one of the strengths of our project is that we work directly with different partners with all different expertise. So we first begin by a qualitative study on the healthcare pathway. One of the main results of this study was to highlight the role of unofficial actors in the healthcare pathway. Due to the lack of caregivers, prisoners called corvées are supporting the infirmary activities. They have a lot of tasks that I will not detail right now. And they are quite similar to the community health worker in the general population, but they have no basic health training and they're never a target population for the health activities. So then at the end of the study, we disseminated the scientific result for a restitution workshop with all technical and governmental partners working with us. So usually it's where studies end, but it's where the knowledge translation process really begins. So together, we co-formulated concrete recommendations based on the scientific result of the study. We all agree to the urgent need to train the corvées and formally recognize their activities in the healthcare pathway in prisons. But at this point, we were totally helpless and we had to ask for a financial support to get help from international experts in knowledge translation. They could help us to train our team for capacity building knowledge translation, and they also help us to elaborate a knowledge translation plan. Then they also help us to elaborate a policy brief during a workshop who implicated all the actors in the prison health sector. One of the most difficulties of this of this elaboration of the policy brief was to find an impactful message to spread and the right target audience to pass to. So this is why our policy brief looks like. And it was also hard to find a consensus on the terms to use. We couldn't not use specific terms as corvée to be understood or use controversial statement as Justice Ministry did not allow us to say that the corvée are essential in the health pathway. So then, in the meantime, we elaborate the training of prisoners involved in the health. So first, we did a need assessment with inmates involved in healthcare and prisons caregivers to determine their needs. Then on this basis, we created training modules and tools with all the actors involved. According to the needs assessments, 2 topics were covered: first aid and symptom recognition of the most frequent disease in prison. We also elaborate visual tools designed for prisons, and we disseminate it. At the end, we train 240 inmates and 33 prison officers. So, since the purpose of this project is to create new activities to improve health in prisons, it is necessary to evaluate the impact of the training. And this evaluation is ongoing actually, and is being done with the help of the expert team. So I can't tell you more right now. But of course, all the results will be shared with all the actors and will serve as a basis for the Justice Ministry to expand the training of the other prison. Our project, the knowledge translation process, will end with a final workshop, bringing together all the stakeholders, prison health decision makers, and future funders. And the purpose of this workshop is to disseminate the policy brief, to share our experience, and to highlight the priorities to guide future projects in the light of the lessons that we learned. So it was supposed to take place 2 weeks ago, due to a lack of communication, it was postponed. So what should we learn from this process? First, it is really important to plan the knowledge translation process from the very beginning of your project. You have to plan a budget and a timeline. You have to involve the stakeholders. I will tell it again and again, but it's one of the most important things. And you will have to design the translation knowledge plan together. And it's also really important to evaluate the activities impact at the end. You will have to train also teams and the key people of the project in the knowledge translation. Then you will also have to think about the continuity, what seeds to sow. So for example, in our project, it was a final workshop, was a good method to suggest solution behind the project. Oh, it will, because it's not happened yet. And be careful and be aware. This is a time-consuming process, so do not underestimate it. And it's also an inductive and participative approach. Engagement of all partners, it's necessary to make an impact. Researcher, government agency, and civil society organization. So pay attention to distribute tasks between all of them. Thank you.
Thanks, Elodie. Fascinating. So for our next talk, we're moving to Farah Nabil. And Farah is from the Universidad de Zaragoza in Spain. And she's talking about promoting health and gender equity through research, ethics, capacity building. Farah, the floor is yours.
Thank you. Hello, everyone. I'm very happy to be here with you today and to present my experiences in promoting health and gender equity through research, ethics, capacity building in the context of a Spanish West African collaboration. So first, let me give you a brief overview of the ethical imperative of integrating sex and gender related variables into health research. There is a significant body of evidence to show that sex and gender affect health outcomes on a population and on an individual level. So therefore, for research to be inclusive, rigorous, and reproducible, we need to include said variables. In the case of West Africa, for instance, we saw that after or during the pandemic and the Ebola epidemic, gender inequalities were perpetuated and exacerbated in terms of socioeconomic deterioration, increased rates of intimate partner violence, and lack of access to sexual and reproductive health services for women and gender minorities. So why is capacity building in research ethics pertinent now more than ever? We saw that after the onset of COVID-19, there has been a surge in research conduct in West Africa and all of the African continent, really. So this means that research ethics committees or RECs need to be capacitated to identify research that has no scientific or social utility, but also research that is gender blind or gender discriminatory. And we also need to go beyond sex and gender and focus on health equity as a whole, focus on other intersectionalities, meaning variables such as ethnicity, race, skin color, religious affiliation, disability status, sexual orientation, for instance, and see how they interact with health inequalities. And this can be tackled by ethics committees through a health equity impact assessment during routine protocol appraisals. So now let me introduce the project in the context of which this collaboration takes place. This is an EDCTP funded project. The first phase was kicked off in August 2019 with Senegal as our partner. And now in this second phase that is kicked off in April 2021, we are 4 countries, namely Spain, Senegal, Benin, and Mali. And we are collaborating with countries all over West Africa and with the Africa Bioethics Network based in Nairobi, Kenya. And our objective is to build the capacities of bioethicists and research ethicists in sex and gender mainstreaming and research ethics, especially in a context of health emergencies and a clinical research setting. And on the left, you can see the map of the project stakeholders, especially the project consortium and the advisory board members. You can see that we represented in 8 different countries between Africa and Europe. And one of the key dimensions of our project is capacity building initiatives in sex and gender integration methodologies into research ethics. So as you can see, we've done many virtual trainings over the past 2 years to allow bioethicists from all over the region to join us live. We also implement in-person capacity building activities, the last of which was a gender mainstreaming and research ethics internship that took place at the Aragon Research Ethics Committee in the University of Zaragoza in Spain for 7 bioethicists and regulatory officers from Benin and Senegal. And it was a very rich opportunity for knowledge sharing about the different realities of bioethics in the different regions. So in terms of where our participants are based, our capacity building participants, you can see that they're based in many countries in Africa. We have 14 different countries on the map, and we estimate to have trained over 200 bioethicists in the last 2 years. And in terms of gender parity, we see that it is slightly skewed towards male representation with 53 to 47% respectively between males and females. So we're almost at a 50-50 ratio. And prior to kicking off our capacity building work package at the second phase of the project, we had a needs assessment all over West Africa for national research ethics committees. And it was clear that there is a strong need for training in sex and gender integration in research ethics, but not only in terms of research evaluation, but also in terms of governance, such as gender equality planning, monitoring, and evaluation. We also have a virtual research ethics secretariat that offers free technical assistance and support to all national ethics committees all over West Africa. And we are currently working with 7 different countries. And we're happy to say that after 2 years of work with Senegal and Guinea-Bissau, they have mainstreamed the gender sensitive standard operating procedures, tools and guidelines that have been elaborated with the help of the project, and they are now implemented nationwide and approved by the Ministry of Health. We also produce open access guidelines, policy briefs, and toolkits in Portuguese, English, and French to make them more accessible on integrating sex and gender related considerations and variables into research design and research evaluation. And we make sure that our content is context specific, because it is mostly for the West African context and the African context as a whole. So we make sure that it is context specific and takes into account the sociocultural nuances of the region. In terms of challenges, first of all, changes in practice and policy in terms of gender mainstreaming into SOPs or guidelines is a very lengthy process due to bureaucracy, but also due to the dependency of national research ethics committees on their host institution, meaning the Ministry of Health in this context. We also saw some resistance to gender mainstreaming, as it was often conflated with the promotion of homosexuality, for instance, gender and sexual diversity, which are taboos in the project-specific region. There was also occasional rejection of the foreignness of the gender mainstreaming concept, deeming it imported, Western, non-African, etc. And we saw that there were gaps in knowledge between researchers and ethics committees in terms of sex and gender in research design. And it hasn't always been easy to engage the presidents and directors of the different ethics committees in the needs assessment research that we conducted prior to capacity building activities. In terms of recommendations to address the challenges, we recommend advocating for the autonomy of the ethics committees so that they can be able to make their own decisions about gender sensitive operating procedures, for instance. And also to adopt culturally sensitive strategies for gender mainstreaming advocacy with emphasis on African leadership to increase the acceptability of the concept of gender mainstreaming in research in that context. We also need to establish synergies and networking platforms between research ethics committees and research institutions to close that knowledge gap that we talked about between researchers and research evaluators. And this can be in the form of training, networking events, communication and dissemination on part of the research ethics committees and so on. And lastly, we also are trying to implement and reinforce an online culture, quote unquote, for research ethics committees in order to facilitate protocol submissions, especially in times of health emergencies such as COVID. Yes, thank you. That's all.
So thank you very much, Farah. So I apologized earlier for losing a speaker, but now I can redeem myself by giving you two for the price of one. So we have now a special offer on our next speakers. So Goodness Odey and Madonna Badom. Goodness is from the University of Calabar, Nigeria. Madonna is a youth advocate with UNFPA, and they're going to talk to us about improved access to youth-friendly sexual and reproductive health and rights services. Thank you. Over to you.
Hello, everyone. Good morning. So my name is Goodness Odey, and we are here to present our abstract titled Towards Achieving Improved Access to Youth-Friendly Sexual Reproductive Health and Rights Services in Cross River State, Nigeria, through the Sustaining Evidence-Driven Advocacy Project, where we developed the first ever Cross River State Sexual Reproductive Health and Rights Policy.
Hi, everyone. My name is Madonna Badom. I'm a youth advocate and was an advocacy associate for the project too.
So we began the project by carrying out a survey in 2019, and this was conducted in Nigeria in 3 states, in Anambra, Cross River, and Abuja. This survey was to enable us to understand what are the challenges and the gaps that exist when it comes to youth-friendly service provision for young people. Specifically in Cross River State, Nigeria, where we carried out this project, we discovered that young people experience limitation when it comes to accessing youth-friendly, non-discriminatory SRHR services. So the major component of the SEDA project was youth policy advocacy and youth-friendly SRHR service advocacy. With this survey and the findings, we concluded on these problems that the limitations when it comes to youth-friendly service provision was as a result of lack of reliable and clear information. Also, providers' discriminatory judgment. So we saw that many service delivery workers, health workers, there was discrimination and judgment when young people want to access these services, then there was no confidentiality and privacy when they want to access these services. And the FP programming was not inclusive in terms of young people being involved in the design and implementation of the programs that affect them.
So what we wanted to do next, following the findings we had, was over a period of 13 months, we put together a 5-man team to domesticate an SRHR policy in Cross River State. Now, that policy was going to be focused on the youth rights, addressing the needs for access to safe, effective, and non-discriminatory, affordable youth-friendly services across health centers in the state. Now, we did this through, first of all, consultative visits to high-level stakeholders in the state, the Commissioner of Health, the Director General, Primary Healthcare Development Agency. We also visited the Family Planning Coordinator, and we put together a multi-stakeholder approach, which was focused on CSOs working on SRHR, young professionals, people living with disabilities, and these high-level stakeholders. The goal was to make a team together that was inclusive and would come together to draft this very amazing policy for us. So the next thing we did was we had policy drafting meetings. Here, this was like the first meetings we had with our stakeholders. Then we had series of meetings, reviews, validations, and the rest of them. And at the core of all these meetings was that this research findings that we made was going to be translated into policy that would be used by healthcare workers, by CSOs, by partners, whoever is doing SRHR services in the state, would use this as a reference to inform their programs and include young people and improve access to young people for youth-friendly services. And as we can see here was the policy validation and launching meeting. That was the last step of the process. We printed over 1,000 copies and distributed to primary healthcare service centers through the Ministry of Health so that it could be used for young people.
So what changed? Because it is very common, especially in Nigeria, where we have a lot of amazing policies, but these policies does not translate into action. Since the launch of the Cross River State Sexual Reproductive Health and Right Policy in 2021, we have seen and have been engaged in increased advocacy and resource mobilization towards improved youth-friendly service provision for young people and looking at a holistic approach where there is government engagement and private stakeholders engagement. Also, the multi-stakeholders approach which we utilize from the evidence generation phase of the project to the policy drafting and launch has also been instrumental for the adoption and utilization of the policy, because we've had various stakeholders reaching out to us to get that policy to use in the work they do.
And while we were doing this process, we were faced with a lot of challenges as usual. One of them was steering bureaucratic structures in domesticating an SRHR policy. For example, we needed approval at every stage from high-level stakeholders like the Commissioner of Health. We couldn't move on to one stage without her approval, and that was a strain to us. And then dynamics of a multi-sectoral stakeholder partnership. Like I mentioned, we had a lot of stakeholders, so navigating those dynamics to get them on board with our objective was an issue. And then we had resistance to change by health workers who were challenging the norms in the state, so we had a lot of resistance to that. And then escaping ambiguity while formulating the policy. We didn't want a policy that was so much, that was too much languages, too much information that would not translate into practice. So those were the challenges we had. And how we were able to solve them was we went digital with the Commissioner of Health. We're so grateful for our help. We recommended that we take some of our meetings online. So most of the approval she was giving us was through mail, which made it very easy for us. And then our multi-sectoral partnership, we had to cut down the stakeholders that were involved in making the policy, in the policy editing, policy review. But at the end, the full house came to validate it with the stakeholders, the governments, and the rest of them. And lastly, the policy was heavily focused on training and retraining of healthcare workers. That was the core of the policy, because we wanted these health workers to change their attitude towards young people accessing SRHR services.
Conclusively, these are our recommendations. Research played a key role in developing this policy, and the action being taken are based on the evidence we have generated. So we are saying that there should be more involvement of young people in whatever you are designing. And this does not just end with young people. Whatever policy you are designing, the population targeted should be meaningfully engaged. Also, partners working at the state and local government level formed a multi-stakeholders partnership committee, which have been critical to continuous engagement. So we had like an accountability group where there will be continuous review of the engagement that has to do with young people, youth-friendly service provision, sexual reproductive health and rights. So we believe that this work is critical, and in the course of the SEDA advocacy project, it didn't just end with the policy, and we hope that we can get more funding support to see how there is continuous engagement, especially with the community health workers, on how this policy leads to more actions and continuous engagement. Thank you very much.
Thanks very much, Goodness and Madonna. Great talk. So that brings us to the end of our panel. I'll try very briefly to sum up a little bit, though I'll leave more time for questions than doing that. But I think it's been a fascinating session of really practical boots on the ground work and showing how research and policy happens in the real world. We've been in the countryside in Bangladesh, looking at the use of community health workers in reducing hypertension with fantastic results there, and then flipping to a very different environment with prison health in Madagascar, and a fascinating study using the training of prisoners to improve their own health there. We've seen tobacco killing 8 million people per year in India, a shocking result, and the resistance by those who have got a vested interest in selling tobacco to change, and some of the issues around advocacy for that important person. On a similar theme, really trying to get data to policy and training. And we saw a great talk from Kutha on creation of policy briefs, the importance of mentorship, and of course that plea for greater open access and making sure that the work of the implementers gets out there. And I think we've all found that any of us who've worked in implementation research, you know, it's very hard to get that published. It takes time, it costs money, but we really need to think about the system to make sure that we're looking at real impact rather than impact factors as we go forward. And in the final two sessions, really starting to look at groups which are often neglected in policy. Really important topic from Farah on research ethics around gender inclusiveness. And, you know, we've all seen in the COVID trials, the lack of representation in those trials and the importance of being representative across both gender representative and geographical representation in those trials. And finishing off with a fantastic talk by Goodness and Madonna. And if anybody wants to tell you that researchers and practitioners can't have a good conversation with advocates, they should watch this performance on YouTube. I think you should take up doubles tennis with such a smooth interplay, but a really important message there about multi-stakeholder, multi-sectoral approaches to engage youth in policy and make them drive policy. So I hope I didn't leave anybody out there. I think we covered the table, but it's now up to you, and I'm happy to take questions. The microphone's on this side, but I will try and make the microphone run. Do we have more than one microphone? Okay, so I can swap sides, please. So.
Thank you. My name is Yasu from Addis Ababa University, Ethiopia. My question goes to Ms. Nabil from Spain with regard to, I think you have recommended that the ethics committees have to be independent fully as well as autonomous. So long they are under institutions, do you think this will be realistic to bring them down to full autonomy? Aren't they going to be influenced by the institutions which they belong to? Thank you.
So if I understood your question correctly, it was regarding the autonomy of national research ethics committees and their dependence at the moment on ministries of health or national institutes of public health. And your question was, do I think that full autonomy could be achieved at some point? So It is very difficult. It's very challenging. For the time being, we do not work with any ethics committee that is fully autonomous, nor in terms of funding or in terms of being able to approve the technical documents, the standard operating procedures without it going through a department of the Ministry of Health at least. But we are advocating for it because this gives the ethics committees the ability to be truly independent, because this is in their mandate. They are supposed to be independent organizations, and they are supposed to have the opportunity to raise funds, and they are supposed to have an independent funding line in the state budget. So for the time being, all we can do is advocate for it, produce policy briefs that talk about the advantages of having autonomous ethics committees, even partially autonomous, not necessarily fully autonomous. And we hope to see it implemented in the future. I hope I've answered your question. Thank you.
Let's take a question from this side at the back first, then we'll move down to the center.
Sorry. Good morning, everyone. My name is Sandra Chilengi from Zambia. I have a question for the presenter on gender and health equity. My question is regards understanding how successful your project has been. And in trying to understand, I want to know whether or not you had any monitoring and evaluation plans. I want to believe that that would be one sure way of seeing or establishing the success of your project. So did you have any such programs, and how did that work? Thank you.
Thank you for your question. Let me just repeat it back to you to make sure that I got everything. So you were asking in terms of how successful has the project been so far, and what are our monitoring and evaluation strategies, is that correct? Okay. Yes, we do have a monitoring and evaluation plan, of course, in terms of deliverables, objectives, indicators, and we have a target for each indicator, and we see to what extent did we meet our objectives. So the first phase had ended on the 31st of July, 2021, and we were able to meet all our objectives. We submitted 100% of the deliverables. We targeted the countries that we were hoping to target. In terms of limitations or shortcomings, we had more engagement from the French-speaking countries than the English-speaking countries, because we were mainly collaborating with Senegal, so we were able to create networks within Francophone countries, but had a very limited participation with English-speaking countries. We also had very active engagement from Portuguese-speaking countries, so that may be one of the indicators where we fell short. In the second phase of the project, we are working with more countries. We are trying to be more regionally diverse and to pay attention to English-speaking countries as well as Portuguese-speaking countries. And we also noticed that the Francophone countries are far more engaged, but we have been able to include more English-speaking countries. We have been able to target more countries. As you saw on the map, we engaged 14 different countries in terms of participation. We also increased gender parity, because before it was almost 2/3 of our participants were male and only 1/3 were female. So now we increased in terms of gender parity. And so far, in terms of our monitoring and evaluation, we are following the plan. We are meeting our objectives. Our deliverables are all in place. So this is what I can tell you for now. And if you're asking about a specific evaluation methodology, it is pretty standard. So we have our objectives, our indicators, our targets, our timeline, and we just follow up on that and see what needs to be done. and try to continuously improve based on the gaps that we encounter and the challenges. Thank you.
Thanks. I saw the person with the orange scarf here first, then I'll move to the center for the next. So I see you and you, yeah.
Many thanks to our presenters. So mine is not a question, it's more about clarity to Farah. Thank you for all of the great work you've been doing with ethics committee. So back to the first question that was asked. I think ethics committees, they are autonomous. I'm from Liberia. I'm Gloria Amazing Ross from Liberia. And even though they have their own challenges in terms of fundings, but when it comes to decision makings, they are autonomous. They are independent. And I think one of the things that is missing is the issue of hands-on evaluation to know what is it that these committees face and what are their on-ground challenges that they face. I think with that, then you better understand, but in terms of they are nominated, yes, they are autonomous. Thank you.
Thank you.
Just a comment. It's a comment.
Yes, I don't need to react.
Yeah.
Oh, okay.
I promised the gentleman there about 2/3 of the way back. Then I'll move down to this row and then we'll move over to the other side. Sorry about that. It really is difficult for the presenters to hear in this room. It's almost impossible for us to do it. So we are apologizing to.
Good afternoon, everyone. I'm Elvis from Cameroon. First of all, I would like to commend Goodness and Madonna for the very excellent presentation. I just want to understand something because, I mean, this is very interesting to see how young people take ownership of addressing a problem that is very important for their well-being. So the survey that you did, was it like an interviewer administered survey? And if that was the case, how what was the type of reaction you had from your peers when you were asking them some questions about their sexual and reproductive health and rights? Considering the fact that most of the time it's more or less a taboo to talk about that, especially among young people. And then the second part of my question is that during the stakeholder consultations that you did, what was the reaction of the different stakeholders when you had to discuss this with them? Because most of the time we are used to the conventional way where relatively older people talk about the problems of young people. How did they react when you came to talk about your problem to them and then trying to tell them what you think could be the way forward? Thank you.
Thank you for your question. So I'm just going to respond to the second question first, then my colleague will take the first. So the reality is that in many cases, you would see a lot of opposition when it comes to sexual reproductive health and right and for young people. But interestingly, the stakeholders we engaged were firstly civil society organizations who were pushing sexual reproductive health and rights in the state. So in most cases, these people stood for young people access to SRHR. This does not mean that they did not have their own personal bias, because we see a situation whereby I'm pushing for this because this is my job, but I also have my religious bias or my cultural bias when it comes to sexual reproductive health and right for young people. So since it's a multi-stakeholders engagement where we had the government, family, the Ministry of Health, the Primary Healthcare Development Agency, young people, we had a way to navigate balancing different perspectives. So when you were bringing your personal bias or religion, we were able to work around the conversation to say, please, let's focus on the objective and also educate such a person to work around their bias. So that was really key for us in terms of the bias. Then we also had engagement with the family planning coordinators at the community level in Cross River State. And interestingly, even though these were health workers, we also got their bias when it comes to young people accessing sexual reproductive health and rights services. And they told us that they don't even have the capacity to provide youth-friendly service. So they don't even understand what youth-friendly service provision is. And they don't know the importance of young people accessing youth-friendly SRHR services. So these gaps were useful for us as we gathered all this information and data and then led to development of the policy. So my colleague will respond to the second question.
Okay, so the first question was what kind of survey was carried out? Well, we had a survey with young people made up of girls and boys and girls in the States. Most of the survey was also online. We used this Google Forms, thank you. So we used that it was all anonymous. But one of the key ways we got our information was through our key informants interviews with most of people, health workers working in the States. And that was done by, this research was carried out by PRB and UNFPA. So it was very extensive and we made sure we went through all the rules and that was how we got our data. Thank you. Thank you.
Thanks. I think given the time left and the number of hands, I'm going to take the prerogative just to ask one last question down the panel, and apologies for those who haven't had their answers, but the panel will sit around afterwards and I'm sure they'll be happy to take you on, but it's just not going to be possible to get round in 5 minutes. And I wanted to make sure that everybody got a chance to speak. So I'm going to ask them for the 30 seconds of wisdom here for people out there who want to make a difference, who want to make sure the evidence gets translated into policy. What's the main lesson you've learned from the work you presented us today? Aliya.
I would say ownership. Until and unless the community or the setting, they don't feel as a part of this research or the problem solution paradigm, they are not going to adhere to any solution and it is not easy to uptake. That is, ownership needs to be happening at the very grassroots level. But also at that top-down approach, ownership is very important, and that ownership has a different form, like the government. Without government support and system support, no benefit can be translated or sustainable or scalable for the longer term. And maybe the government ownership has to be different in a way of investing in research. So if government can invest in research, they will like to see output of it. And this is how we need to do both community ownership and also government ownership at the same time. Thank you.
Very wise. Vivek.
So I think research has to be context specific and also community led and also practitioner led. In our regional consultation, what we realized that the stakeholders who represented different states, they had very different contextual contexts, despite coming from the same country. Different kinds of barriers existed and different kinds of learning points and takeaways that they could learn from each other. So that's one thing that I would suggest. And the other thing is that the context that is central, that has to be that has to be the determining factor on designing research programs, designing projects, and also implementing them.
Kutha.
So for me, I would say that having the people who the policies are targeted at, being part of developing the policies themselves is actually quite key, because one, they get to understand the importance of the data that they're collecting, they get to put in more efforts. And also, once this policy is enacted, they'll be happy to implement it because they were part of the process from the beginning. So I think that would be a key takeaway for me.
Elodie.
So for me, it's, as Kutha said, it's involving many partners with from the beginning, and we all have a different expertise. So we can build together something from the beginning to make a difference. And it's also really important to involve several hierarchical levels. For example, for the Justice Ministry, we did the mistake to involve only technical person at first, but in fact, you have to go by yourself from the top of the institution, and also with technical partners. It's really important when, especially when you arrive at the end of the process, and you have to involve the stakeholders.
Thanks, Farah.
So I would say if you're working in the context of a multinational project, especially between low resource and low income and high income regions, to make sure that there is equitable and fair partnership practices in place in terms of resource and benefit sharing and decision making. And also, we need to work on a solid communication and dissemination plan for our findings that is culturally congruent, that takes into account the different barriers to knowledge reception and retention between the different population groups, so that everyone benefits from the findings. Thank you.
Thanks. Goodness.
I'm just going to strongly re-emphasize the importance of inclusivity, which came out strongly in the CEDA project. So we can't say we are targeting a particular population through our research and our actions without including them. In addition, the importance of shared interest and distributed leadership. As much as we needed the government buy-in to push for that policy because it is a government-owned policy, we had to see how the interest of the funders, the interest of young people, the interest of the government was aligned for us to achieve the objective of the project. And distributed leadership is important because after the policy has been developed, what next? The actions that needs to be taken and continuous engagement. Thank you.
Thanks. And the final word for Madonna.
Okay, so what I would suggest is that as researchers, as people working to put research into policy, not one size fits all. You should be innovative, find innovative solutions to your problems because these problems would always arise. For example, we had so many issues and we had to be very creative with guidance from the government, with guidance from our funders, from our country managers. We were able to navigate this. And also another thing we strongly believed in is that we didn't want an ambiguous policy. Our policy is not up to 100 pages. So it's something that it's a booklet anybody can pick up and understand with clear and concise information. So that is why it has had success with people using it from CSOs, partners working on SRHR in the state, and even healthcare workers. So those are the two things I would like to add. Thank you.
Thanks, Madonna. And so all it leaves me to do now is to finish by asking for you to show your appreciation to a fantastic panel.